everybody needs to eat a diabetic diet because it's a fiber-rich food diet.
Wow.
So whether you have diabetes or not, whether you have pre-diabetes or not, we all need to be eating this way because that's really what's going to sustain our health as we get older. So we need to model that. So it's not homes where, oh yeah, I have diabetes, I'm just going to cut back sugar. The rest of you eat all the sugar you like. So how do we approach this? Again, it's understanding why you're doing it. It always has to go to the why. And that's what I had to do in my home.
Hello, everyone. This is Dr. Lwanga. I'm here with my friend, Dr. Babalola. She is a family medicine doctor and a DPC doctor that is located in the Atlanta area. Just before we started recording, we were talking about her background. She has a background in academic medicine and transitioned to opening her own practice. And she has written 2 books. So she's a wealth of information. I'm so excited to have her here. Thank you so much for agreeing to be on our show. Please tell us a little bit more about yourself. Tell us about your journey, which I'm very interested in. Your journey into medicine. I'm sure you have a lot of pearls to drop.
Yes, thank you so much, Dr. Lwanga, for inviting me to your podcast. It's an honor to just share space with you today. So my name is Dolapo Babalola. I am a family physician, and I'm also the owner of Living at Your Finest Wellness, which is a holistic and integrative direct primary care practice in Atlanta, Georgia. Yes, my background, I started out in academia. I went to Morehouse, stayed on as faculty, and just loved to teach. So in the midst of that 16 years, grew to be the medical director for the undergrad division in the Department of Family Medicine. I was also the clerkship director. I love a lot of research. I'm data driven, so I did tons of research. Definitely became a full professor. I'm just grateful for that opportunity. And I cared for patients. I love to care for patients. And in the midst of it all, I was just constrained with the time and how much I could care for my patients. And it went from 20 minutes, 15 to 10 minutes. And I had to do my own healing because I was burnt out, the terminology that a lot of people have heard. And I just didn't feel like my patients deserved the kind of limited care. So I got additional training in lifestyle and obesity as well as menopause. And I thought, okay, it's more clear to me now that 10 minutes is not enough to adequately care for my patients. Then I became really bold when I heard about direct primary care, which is a membership-based practice. It's not insurance-driven. I can take as much time as my patients need to care for them. So I ventured out 2 years ago into my own DPC practice. So that's been my journey so far. And I'm really excited to share more about that journey with you.
Wow, that is so amazing. And leaving academia, it's not an easy journey at all. I think a lot of us, when you're graduating from residency, you have the option to either go into private practice, corporate medicine, and academia. And academia is what we all initially aspire to do.
Yeah.
And it's so rewarding, especially also hearing that you had the opportunity to do research and to mentor and teach others. So I can imagine that was a challenging decision to make on many levels. Tell us a little bit about your thought process and how you made that decision, even for those who are not physicians. I think there's important information or important things we can learn about choosing to do things that are maybe against the grain or not what your peers or friends are going to agree with.
Mm-hmm. Yeah, so that journey, I always tell people I'm not one of those that would tell you I wanted to open up my own practice. I really just wanted to take care of patients. And if that was in the academia setting, all well and good. But I felt over the last 7 years, I was like, yeah, this is not going well. I did everything possible to improve where I was working, help to achieve optimal well-being. I had ran a diabetes group visit for 3 years, but then they canceled it. So everything that I was trying to help my patients live healthier lives just had a lot of red tape. There's so many people you had to talk to. So the last 7 years of that academia, as much as I enjoyed teaching and caring for my patients, I felt like my personality need to connect with my patients. And so I wasn't the person that would be writing my notes at the same time seeing the patient. And then that means I would have, at the end of the day, 26 charts to complete and not going home. And so it just became very monotonous, very strenuous for me and my family. And the reason why I went into academia, yes, I am passionate about teaching, but I also had little kids and I wanted to be in their lives. I wanted to be present. I'm that mom that really wants to be in everything. So I felt that was a good start. And so I was able to have the flexibility, especially especially when I got the additional roles in admin. I was able to balance my time. But then as I got older, and then the increase in number of patients that we had to see versus the quality, then I needed to find something different. Now, when I say something different, I knew what the insurance-driven world was like, and I figured the grass always seems greener on the other side. I didn't want to hop into anything else. If this was really going to be it, if going to another practice was going to be the same thing, there was no point until I heard about direct primary care. So in terms of the decision, yes, it took a while, but I had to find something else that would help me provide valued care. And when I found it in DPC, then I took the boldness and I leapt over it. So it was a journey, but I'm grateful for every time that it took me to figure out what was the best match. I did apply for a few other practices that see patients the way I see, but it was out of state. And I figured, my family said, bye, we're not going with you. So I figured if I can't change the system, I might as well create my own system. So that's where the joy of opening up my own practice started off. And it's been a great ride. It's been 2 years, and I'm just so grateful for the patients that I have and for the opportunity to practice medicine on my own terms, serve and earn, like we always are taught.
I love it. And I'm so curious about lifestyle medicine. You have additional training in lifestyle medicine and menopause medicine. And I think I heard you say obesity medicine as well. Well, so for our audience who does not know what lifestyle medicine is, what is lifestyle medicine? How are doctors who practice lifestyle medicine different than other general family medicine doctors?
Lifestyle medicine is just really a medical specialty that uses evidence-based approach, right? Where we talk about lifestyle habits and our behaviors. So you use those as the primary treatment modality. All right. So for instance, if somebody comes in with headaches, I definitely want to do my differentials as a family physician. Is it neurological? Is it because of allergies? What's going on? But I also want to find out about their stress. What's going on in their life? Are they sleeping well? Is it stress related? Is the foods they're eating? So that's what lifestyle medicine is. It's a medical approach that uses evidence-based interventions when we talk about our habits and behaviors to dive into what's going on with the patient. And there are tons of evidence that show that not only does it prevent lifestyle related diseases, it can also treat, not just manage, but also reverse. So what makes me different from others that are not? And just want to say here that a lot of people, a lot of our physicians, not just family physicians, emergency rooms, just name the specialty. When it comes to talk about lifestyle, everyone should have that background. It really should. And the American College of Lifestyle Medicine is promoting it in residencies, promoting it in medical schools, so that we have that foundation, because we're just not trained enough in nutrition. And so hopefully we'll get more. I know when the program started, I believe in 2004, very few people, but they've increased in membership, and a lot of schools are making it a part of their curriculum. So what makes me stand out? Certainly with that knowledge, I can take a deeper dive and focus not just on the symptoms treatment, but the source of the problem. And because in the DPC forum, we have time to do that. That's the beauty of it. Imagine having 10 minutes, 15 minutes. You can't really take a deep dive. You can touch the surface, but if that patient needs to come back, it's difficult to get back into the clinic. I had a 3,000 patient panel. They will wait 3-4 months just to get back in to see me. And then the patients are double booked. But I did my best to just dive into all these pillars. And they all left really empowered and just felt hope. Like, for instance, a 29-year-old guy, blood pressure was really high, was already on 3 blood pressure medicines. And I suggested, what can we do? He said, add a 4th blood pressure medicine. I said, wait, hold up. Yeah, let's dive into what you're eating. What's your sleep like? And I tell you, by the time I saw him a month after, his blood pressure was well improved, that we could start tapering. So lifestyle medicine allows you to deprescribe because you get to the root cause. And I have my own personal story with that. When I had blood pressure as high as 220/120, 3 blood pressure medicines could just keep it stable, but not reverse it until I got to the root cause, which was the stress and the foods that I was eating. So that's the beauty of lifestyle. Every field, every physician should have some foundation in it. And yes, there is actually free CME for anyone and I'm happy to share that information. for any physician that wants to dive into it.
Yeah, wow, that is fantastic. And I think that is what patients want. And I think that is potentially what a lot of us thought medicine was going to be like before we went into residency. We're like, okay, now I'm going to learn how to fix this. I'm going to learn how to reverse this. And then you realize the medical model is more for emergencies, more for urgent issues to fix this quickly. We don't, as you mentioned, or we're not taught how to reverse a lot of these conditions. And oftentimes we don't have time. So it's so incredible that you took that journey, and I'm sure your patients really appreciate the fact that you take more time to talk to them and you find the root cause and you are reversing things. So I think that is fantastic. And I want to touch a little bit more on menopause. So tell us a little bit more about why you decided to get additional training in menopause and what are some of the common symptoms or conditions that you treat.
Yeah. So menopause is a buzzword everywhere. I don't know if you're hearing a lot of it in Canada as well. So it's everywhere. Yeah. So I pretty much going through my own journey. I'm 49. I'll be 50 in December. So going through my own journey when I was in academia, that was also another thing that we got very little training, right? We were taught, just live with it. You'll be fine. It's menopause. You're getting old. That was the conversation, unfortunately, that I was having with my patients when I just had limited knowledge. We were also taught not to check any labs. And again, everything is patient-centered. There's room for checking labs, and there are times where you don't need to check labs. But so for me, I needed to find out what was going on with me, number one, to get the additional training, and also to help my patients, because a lot of them were complaining of all sorts of symptoms that now with the additional training, I know can be attributed to that transition, midlife transition from perimenopause to menopause, postmenopause. I found out that even our OBs that have fellowships, they weren't taught anything enough to even help the patients. And so that's why I got that additional training. And it's been great. Patients come back feeling like themselves again. I know that, of course, when I talk about my protocol, it's a 3-way protocol. Lifestyle is always the foundation, right? We cannot do the same thing the same way expecting different results, right? So if you're eating just any way and anyhow, as we age, our body naturally loses muscle, bone. We have to tweak that. So I have what I call lifestyle redesign. And then I'm also really big on herbs and spices and botanicals. And then some people might need the bioidentical hormones. And really all that means, I'm not referring to it has to be compounding, but I'm referring to the fact that you need the natural hormones that your body physiologically makes. Those are the 3 protocols that I follow, and I apply it to every patient that needs that assistance and figure out what will be the best to enable them to achieve optimal well-being.
Oh, that's fantastic. And I can think back as well in my own practice, many patients that have different symptoms that are definitely due to menopause. My training is not in how to manage menopause. So I feel quite limited and sometimes it's almost helpless in terms of how much can I help my patient when I know other people have told them you're making this up, or, oh, you're getting old. Okay, deal with it. Or you're a woman. And they're like, okay, that's nice. But what do we do with this?
Yeah.
So I think it's awesome that you took the time to get additional training to really help your patients. And everything you're saying, like every time you talk about what you do, you're always going back to it's about your patients. It's about serving your patients, not at the level that we were taught at residency, but I can tell you really want to serve your patients with excellence and get them up-to-date information, which is so fantastic. I'm sure your patients are so grateful for all that you do for them.
Yes, they are. And I'm just honored to be part of their journey. So it's a blessing. And the more you know, the more you're empowered, right?
Yes.
You have the facts and not out of fear. So that's why I always want to know enough so that it's a collaborative conversation about this is what we have, this is what the evidence shows, what is going to be suitable for you. Yeah,
and evidence. I love that evidence as well, because in this world, there's a lot of stuff going on. I think one of my big pet peeves has been this pink Himalayan salt. I don't know if you've seen those commercials.
Yes.
Talking about using this Himalayan salt to make Ozempic. And speaking of Ozempic, you also specialize in obesity medicine. Tell us, like this pink salt business. Maybe we'll talk about pink salt later on. Tell us a little bit more about what is obesity medicine for people who've never heard about this.
Yeah.
What kind of patients do you help when you focus on obesity medicine? What are some of the common treatments that you offer and suggest? And what are some of the lifestyle modifications that you recommend your patients?
Yeah, so obesity medicine, people hear it and they're like, oh, yeah, is it for real? People just need to eat less, move more. But the whole organization, the Obesity Medical Association, has been in operation for many years. And I believe, trying to remember when it became a chronic disease, obesity itself was coined a chronic disease like diabetes. And that's because it's complex. It's a combination of physiology, biology, neurotransmitters. It's a combination of things. And so that's what obesity medicine addresses. It addresses the root core of all of those different components that make somebody obese. And when we talk about obesity, it's how much adipose tissue that one has. So we have overweight being a BMI greater than 25 to about 29. And then when we talk about obesity, it's anywhere from, and we've changed it. It used to be morbid obesity. Now it's class 1, 2, and 3. So it's based on how much your BMI is. But for me, additional training has enabled me to not just look at the weight on the scale, because BMI, as a few people already know, it's populational based. But with an in-body scan that I have, I am really looking at the percentage body fat and visceral fat, because that's the fat around the organs. I'm also looking at skeletal mass, because that's where the metabolic dysfunction comes in. That's what obesity medicine is. It's multifactorial. Definitely lifestyle is incorporated. Lifestyle, how do you eat, how do you drink, how do you move? But then some people need additional support with weight loss medication, which is FDA approved. We have the first generation and the second generation, which is what you were talking about, the GLPs. So there is place for the use of the injections, but for me in my practice, I always want to make sure that it's patient-centered. They have to have a true indication for it to be able to prescribe it, and then they have to be monitored closely, because if you're not just taking medication off the street, then you're not using it best practices, and then those are the ones that would have lots of complications. So that's what the field of obesity medicine is, really helping patients that have struggled with their weight, and it's not just the one factor, it's multiple reasons for, so we get to the root cause of why they struggled with their weight.
That is amazing. And I think that's so perfect, because in this world that we live in today, we're going to get to this pink salt business. I think a lot of people feel helpless. People who struggled with their weight feel very helpless, because if you don't have the keys, it's very difficult to lose weight. And I can relate to that, because as weird as it sounds, my background was in exercise physiology. I was an athlete, and then working as an attending, you're not stressed out and you have money to eat whatever you want to eat. I started putting on weight, and no matter what I tried with what I thought I knew, I couldn't lose weight. And then I got a nutrition coach, and the few keys he gave me made a big difference. So I love what you're saying about looking at the root cause, because it was about the root cause. But I think when we don't know that, we feel like, okay, maybe Ozempic, tirzepatide, any of these medications are the only option. And I also feel people are also sometimes nervous, which, I mean, rightfully, you have to go in with your eyes wide open, nervous about starting these medications. They ask me, okay, so what happens when I stop taking the medications? And in our healthcare system, the government or insurance company is not paying for it. Even if you meet the criteria, you're paying cash for it, because resources are limited. So people are thinking, I'm spending $300 a month on this medication, which I know from my American friends, that's not too terrible. But yeah, they're spending this money, and then you're going to stop it maybe in 6 months. Once you reach your goal, are you going to gain the weight back? Do you throw that money away? So people are looking for other alternatives. And speaking, I have to ask that question. Is this Himalayan pink salt, does it replace Ozempic?
All right. So that's a $1 million question, right? So when it comes to, and everything you said is absolutely correct. For me, I know that there's so much information. I have patients come to me all the time asking me about the salt, the natural GLPs. It's just a commercialized country that we live in, whether I think of US more than Canada. So you're going to get so many influencers, so many people that something has worked for them, and all of a sudden it's the gold, right? So when it comes to pink salt, let me backtrack and just talk about what GLPs are. It's a protein. We naturally make it. It's just that it's short-lived. So the pharmaceutical company, they've done tons of research and studies and showed that they could extend the half-life, an injection every week, to make that GLP last longer. It works on multiple sites, right? The pancreas, the brain, it decreases motility, it increases your satiety, the reward centers. So that's what it does. But I've seen a lot of people have come out to say there are things that stimulate GLP, which is true. As if you exercise, that just moving by itself, you get all the endorphin rush. Even the foods that you eat, if you eat fiber-rich foods, your food is going to digest slower, not as quick, right? If you're eating more sugar, your food is going to very quickly, you get those glucose crash. So it's a multifactorial thing. So there are many things that naturally can stimulate our GLP. With the injections, though, you have an extended half-life, 7 to 10 days. You will get the effect and the benefit of the injection. Now, with the pink salt story, again, it's an indirect way to increasing our body's natural GLP. As to whether it's going to give you the amount of weight loss like you get with the GLP, based on the studies with the Zepbound, the tirzepatide, is anywhere about 45% of your body weight loss. You're not going to get that amount. So with the pink salt, it's just really hydration. Your body's using water better. The more water we drink, because we're 70% made water, you're going to feel fuller. That's why. So a lot of all these things that come out and they say they work in isolation, they don't. It's really what's happening. So that's where the story with the pink salt comes in. It stimulates your body to stay full, your satiety, you're not eating late at night. And when you're not eating late at night and you're actually sleeping better, then your hormones are regulated better. So it's an indirect of losing weight, but is it going to give you that amount of weight loss that you need with the injection? It's not. But it's small changes give you the end result that you need. It's not those big things, because if you do the big things and you miss out the foundation with lifestyle, you're going to gain it back. Even if you take the Ozempic and whichever weight loss medication, whatever you're doing, you're going to gain it back. So that's why my system for anyone is whatever you're going to continuously do is the option that you should follow. If you're going to do, people say they do keto to lose a lot of weight. Once it's not sustainable, you go back to business as usual, you're going to gain the weight back. So that's the whole spill about the pink salt. Now, I do encourage some of my patients, especially with my in-body scan, if it shows that they have a lot of inflammation, and if it's not joint issues, their body is not absorbing the water well. So I do tell them to put a little bit of pink salt, but not with the goal that is supposed to help solely to lose weight.
Okay, thank you for breaking that down. I was extremely skeptical, but I learned something. Like the first thing for sure, to do my research, because I didn't necessarily do the research. I just assumed you're taking more salt, you're going to retain more water, your weight will go up. But there is something to this, but not as effective as people presume it might be. So thank you for clarifying that.
Yeah, no problem. It's again understanding the evidence behind all these things that come. And I always tell my patients, tell me, I would like to learn, let's learn together. But just hearing something and jumping at it is not in your best interest, because just because it's not one size fit all. There's a general concept to things, and for that person, you don't know all the details. But there is some studies about the pink salt, a little bit of it, just the same way I try my best every morning to drink warm water with lemon, because it's an anti-inflammatory. It helps me start out my day. It's the same way with the pink salt. So if you start your day, then you're likely to be eating all the crazy stuff. And so it's a vicious cycle that goes on if you start off in the right track.
Yes, that is very true. If you start off like eating well, definitely makes a big difference, even in your mindset and what you're going to choose. And you mentioned something about, you said in-body scan.
Yeah.
Tell us more about that. What is that?
Yeah, so an in-body scan is pretty much a scan that does a total body composition. So it's beyond a scale. All right. So we go on a scale, it tells us what our weight is. That could be very discouraging. I've had a love-hate relationship with scales, because I have one in every floor of my house. But then it discourages you. If you're on your cycle, it doesn't tell you, is it fluid overload, what's going on, if you're stressed, but it gives you information about that weight. It tells you how much of that weight is from extracellular water, from intracellular water, how much of it is from fat mass, as well as skeletal. So it dives into how your muscle is distributed. So that's what I love about it. Ever since I've had it for 2 years now, I've definitely broken that love-hate relationship with my scale, because I don't see a number in isolation. Like, for instance, I've had even patients that I'm managing with menopause, once they start doing some strength training, even if they're on GLPs, when they see the weight go up, they see that it went up because it was muscle, not fat. And percentage fat decreasing. So for women, we're supposed to, our percentage body fat is supposed to be between 18 and 28. Anyone above that, then you're increasing your risk of visceral fat. So that's what an in-body, it really takes a deeper dive into what that weight is consisted of so that you can come up with an action plan that is specific to your numbers instead of just working blindly. That okay, yeah, I when I had my diet culture, I used to be any diet, just name it, I've been on it. When I gain weight, want to do a crash, and unfortunately, I will lose the weight, but I was losing muscle. That didn't help because losing muscle gain the percentage body fat. Muscle is a metabolic organ. So if you don't have that muscle, then I'm gaining fat. So you feel happy that you've lost weight, but most of it was just water weight and muscle. And just empowering people to understand what that entails. With my patients, they love to come get their in-bodies just to keep them on track. And I can provide some action plan that is really specific to them.
Yeah, that is amazing. I really love hearing about that and hearing the details. And I think there has been some controversy with BMI because people talk about, say, a football player who's really muscular. His BMI is going to be high for his height. So BMI is not the end all be all. It's not that accurate. So I can see the value of the in-body scan. So I want to pivot a little bit more to some of the things we had wanted to talk about. The one question I want to ask you is for, say, parents who are on a weight loss journey and they have young children. Do you have any tips on how they can ensure that they're not negatively impacting their children in terms of their relationship with food while they're trying to lose weight? Because I think it can be quite challenging to have young ones. So you're trying to feed them nutritious food. You don't want them to struggle with their weight either, but you don't want them to have a difficult relationship with food as well.
Yes, that's a great question. I love that you asked that because in my family, it is technically very relatable. And this is for everyone. It's whether, you're struggling with weight or not. I always tell my patients that in the past, when I used to run the diabetes clinic, and I did that for 3 years, I would say, everybody needs to eat a diabetic diet because it's a fiber-rich food diet. So whether you have diabetes or not, whether you have pre-diabetes or not, we all need to be eating this way because that's really what's going to sustain our health as we get older. So we need to model that. So it's not homes where, oh yeah, I have diabetes, I'm just going to cut back sugar. The rest of you eat all the sugar you like. So how do we approach this? Again, it's understanding why you're doing it. It always has to go to the why. And that's what I had to do in my home. Now, I grew up a sweet tooth. I say that all the time. I wish that was not the case, but sweet tooth. We always ate after we had a meal. So I do enjoy eating plant-based foods. And when I say plant-based foods, foods that are close to the ground as possible. So your vegetables, your whole grains, your nuts and seeds, any of those that are not animal-based is pretty much considered plant-based. So I enjoy eating those, but we always had a dessert. So over the years, my dopamine hit to my tongue, taste buds had been configured into always wanting sugar. But when I started getting older and I saw, okay, joint inflammation, I'm hurting, I have a piece of cake and I can't get up anymore, or blood pressure increasing because of weight, I had to slowly realize that the diet culture was not going to help me because it wasn't sustainable. And so my kids, I have 2 girls and a son, and so they would see me do the crash course, and when they saw my transformation, I had to tell them, I said, that's not a healthy way to lose weight. You want to lose weight because you want to be strong, you want to have a strong brain. So this is conversations that we have, and that's where I encourage families to have this sit down and come up with why you're doing what you're doing. So I now encourage, and my girls see that, and so they strive to eat healthier. We do our best to eat as clean as possible, but not in a restrictive way. If we have a slice of cake, we divide it amongst everyone so that one person is just not eating the whole cake, right? Because of the calories, the sugar, the inflammation. In terms of answering your question, I hope I'm answering it and I'm not rattling away, but it's really a family conversation that we all want to be healthy. Just because you're young, yes, your body might burn more, but long term, what is it doing for your brain? What is it doing for your gut health? Can we try at least 80% of the time to eat well together? And in my home, out of sight, out of mind. So our house is filled more with healthier options. And if we do have on birthdays and if we go out and we indulge a little, we just make sure that we don't overindulge. So that's a way to start. I do want to say that it doesn't happen overnight, so be patient. Be very patient. I remember There was a time after I got bored eating lifestyle, I just went into the house, got rid of all the milk, all the cheese, and everyone protested and was like, hold up, what's going on? I was like, so I had to gradually explain and bring things back and let them understand for themselves, do their own research, test and see how do you feel when you eat all of that versus when you eat food. So it's a process. Give yourself grace, get the information, and come together as a family to have those conversations and see what will serve you well. So that's my response and how I've been able to deal with it and how I help my patients transform their nutritional profile.
Wow, you say so many amazing things. I love how you talk about educating your children. Like, it's not just lecturing them, but explaining the how and the why so that they really understand the reason to eat. It's not food tastes good, yes, but it's about nourishing our body. And we select these foods because it's good for us, it prevents disease, and what kind of foods to select. And also letting them experiment as well and see, oh, yeah, oh, this does not necessarily agree with me. Eating all of this, I went out to XYZ and I don't feel wonderful. And now I eat this healthy foods and I feel better. I think allowing children to do that, or even young adults to experiment and see how they feel, is very important. And I also love the tip about sharing cake. Especially in special occasions, we're not going to say no to a birthday cake.
Oh, yeah.
Putting it among everyone makes us still enjoy our food and have a smaller portion, but we're all sharing it together.
Yes, you're sharing the calories.
So the last question I'm going to ask you, I still have so many questions I'd love to ask you. I'm going to have you back, but I'm going to wrap it up and ask you one more question. Okay. So say there's a parent who has a young child that is struggling with their weight. They see their child is struggling with their weight and they want to help their child, but they don't want to make them feel bad, or, as we were talking about, put them into this cycle of crash diet or introduce eating disorders. And they're not sure how to even begin to broach this topic. What would you suggest that they do first?
Yes. So it's going to go back to, we have to be very careful. That age, oh my goodness, the way we speak. And I'm so glad that I took the course, the obesity medicine certification, because it has changed the way I speak, how I address obesity. You have to certainly use friendly words. So not saying fat, not saying, even though I'm not a big fan of the word obesity either, but that's the field. We're talking about being fat, are we talking about being heavy, extra? So number one, speak to the child. And I'm speaking from experience because my first and my youngest have struggled with their weight. Meanwhile, my second child, she can eat all the world and she doesn't gain weight. So the other two, I was like, why aren't they burning not as fast as the middle child? And so the language that I use has to be user friendly. I have to let them understand that, get to the root cause. Everybody's designed differently. Our metabolism are all different. So having that friendly approach and not name calling will be important, that you start there. And then also you definitely need help with a specialized physician that understands how to get to the root cause, because some people, their leptin, these are the hunger hormones, as well as the ghrelin. The ghrelin is the hunger hormone and the leptin is satiety hormone. You need to get to the root cause. Why are they gaining weight? Is it the food? Is it lack of sleep? Is it stress? Understanding the root cause will determine what will be the treatment modality. So lifestyle, certainly studies have shown anywhere from 12 to 15% body weight loss, but if that is an option, depending on age, it is approved for 13 and above. So I know with injections it's a little bit tricky because you don't want them to get a eating disorder, and they have to understand that is just being an additional layer, and it's not substituting the lifestyle. For that child, the parents, it's really going to come down to what they keep in the house. They really have to do it as a family. You cannot expect the child to lose weight on their own. Meanwhile, you're bringing all the things that are not healthy. I had a lady, she was 19, and even though her mom brought her to me, when we sat down and we were having a conversation, she said, my mom has always been thin. She does not understand my struggle. She still brings cakes in the house. She still brings all the things. And at least personally, I've seen it's always going to be skill over will. I don't have any willpower when it comes to sugar because that's how my brain has been wired. So I have to provide the skill, fruits as dessert, substitute things that, and keep things that are going to tempt me out of the house. So it's pretty much, that's where I will start. If medications are needed, said, certainly it has to be approved for that age range, but then they would need to understand that the medication is not going to solve all the problems, right? But then I also affirm them with the InBody. I have a guy, he's 21. He just came last week. He saw how just making a little tweak of not eating every day fast foods and just cutting it to one, he saw how his body fat went down. He saw how he doesn't even exercise but 2 times strength training. So when you see that, it encourages them, right? And you affirm them. Even if they have a setback, encourage them. This is a journey. It's a lifestyle journey, and nobody's going to accomplish it. As long as you live in planet Earth, we're all at some point or the other going to have to figure out how to make adjustments. So that's what I will say. It's multifactorial. We probably are going to have to get a dietitian involved, a psychiatrist, depending on what really is the root cause of the problem. So that's the approach that I will take.
Wow, that is lovely. I really love how you dove deep and give really practical advice. And I love the tip that you give, that it's the skill over the will. And I think that's anything in life, any habit we want to break. We think I'm going to do X, Y, Z. And then if the system's not set up to support you, it's not going to happen. So I think that is very important. Thank you so much for sharing that with us. I really appreciate it. And thank you so much for sharing everything that you shared with us. I know there's so much more to share, and I have so many more questions. So I'm going to have you back when you have time. I'd love to have you back.
Yes. Thank you. I love this conversation with you. It's important that we have these meaningful conversations so that people feel empowered. They know they're not alone. I've had my own struggle. We've worked through it, and we're still working through it. So I appreciate you for having this space to help your community so that we can all be healthier, because that's truly my goal, to prevent chronic lifestyle related diseases, because it's increasing. And unfortunately, my youngest patient with type 2 diabetes is 9 years old. It's happening. And it kills me when I hear this, especially in the Hispanic, Black community. We tend to have more of this chronic lifestyle related diseases. And pediatricians right now, compared to the pediatricians in older age, they're seeing more diseases that they never saw. Right? From that age 1 to 21, they're seeing a lot more now. So we definitely need to have more of these conversations within our homes, within our communities. Just because you have a genetic disposition to any of these chronic lifestyle related diseases, it's the habits and behaviors and environment that pulls the trigger. So we need to keep having these conversations. So thank you. I appreciate the time with you.
It's my pleasure. And for all of you who want to learn more about Dr. Babalola, we will make sure that we link her website below. And you have a podcast, right?
Yes, I do.
Yes. So we'll make sure that we link your podcast as well for our listeners who want to listen and learn more about you. But thank you again for being on our show. And to our guests, bye-bye for now.
Bye.